an NSO can start by describing the eligibility. And next, if the veteran and the NSO see that the veteran is eligible and likely could benefit from the program, the NSO could actually assist with completing the form if need be. It's a relatively simple form. I think it's one page, but if need be, the NSO could help complete the form. Now, the veteran and the caregiver or caregivers would actually have to sign the form. This is one of the forms that mentions that you're certifying. Therefore, the applicant actually has to sign as opposed to the accredited representative signing. The NSO can also follow up on the claim. I know sometimes, in my experience, I've had calls from our clients and they're concerned that the VA has forgotten about them or the VA has misplaced their claim or something of that nature. So if that occurs, let's say, for example, you've submitted your application and it's been 30, 40, 45 days, and the veteran's concerned, then the NSO can be contacted, and the NSO can actually do the legwork to follow up on the claim to make sure that it's not been misplaced, that it's still pending, and then maybe reassure the veteran that yes, she or he will receive a decision. An NSO can also put the veteran in touch with the Caregiver Benefit Program coordinator. Each VA medical center has a coordinator, and there's actually a website for this. It's www.caregiver.va.gov. On this website, you can look geographically to find each VA medical center, and then each VA medical center is going to list the name of the caregiver coordinator and his or her phone number and extension. So the NSO can provide that contact information if need be. So looking at the totality of what an NSO can do, the NSO can start with the eligibility, run through whether it appears as if the veteran qualifies or not, then actually start the application process by helping with the form. And in some instances, if need be, perhaps the NSO could send the form to the caregiver if there's some type of barrier with the veteran being able to do so for himself or herself. And then the NSO can follow up on the application once it's been submitted. So, and also give contact information. So really, the NSO can provide a lot of information and a lot of assistance along the lines of the Caregiver Benefit Program.
Thanks, Doug. And you mentioned that all of those applications that were denied, an NSO could have helped them. Can you explain how an NSO can help a veteran if their claim was, if their caregiver benefit was denied?
Certainly. When any claim is denied by the VA, I think a really thorough NSO will look at the reason why it was denied. The VA is supposed to give a clear explanation why any claim is denied. So the first step an NSO should take is if the NSO could look at the denial letter, and the VA should be providing a letter specifying the reason for the denial. So the NSO could look at the denial letter and then look at the evidence and then look, okay, what happened here? Why was this denied? And if it is a decision perhaps that was maybe on the fence, there was some gray area, or the VA just blatantly made a mistake, then that NSO could submit an appeal to the VA for that benefit. So the caregiver program is a medical benefit, so it is considered a clinical appeal, and that is one that goes to the VISN, and actually the NSO could write the argument for the appeal and submit the appeal for the veteran. But first of all, Roscoe, I really think the first step is a good discussion with the veteran after reviewing the VA's denial letter. because in some instances, perhaps an NSO didn't help with the initial claim. And let's say, for example, the veteran did not have the appropriate service-connected percentage. Let's say, for example, the veteran was only 40% service-connected, where the criteria is 70% or greater. So the NSO is only going to appeal if there is a legitimate argument to make. So the first step would be looking at the denial letter, determining whether there was a legitimate denial or not, and then filing an appeal if warranted. Once the appeal is submitted, the NSO can also follow up on that if it's not timely adjudicated.
Thanks, Doug. So if a veteran doesn't know how to contact an NSO, is there a website or somewhere they can go to find the nearest NSO?
Yes, that is actually on www.pva.org. You can go to a locator there, and it's state by state to find his or her local NSO.
Great. So we talked a lot about the Caregivers Program. And as you know, some veterans obviously will not be eligible for the Caregiver Program. Can you explain what other programs veterans who are not eligible for the Caregivers Program could assist them with their home health care?
Sure, certainly, Roscoe. There is a benefit. It's certainly quite broad, in my opinion. It's called Homemaker Home Health Aid Hours. Now, the homemaker aspect is getting assistance in the home with what's called instrumental activities of daily living. And this is going to be light housekeeping, perhaps meal preparation, maybe in some instances grocery shopping, things of that nature. That is the homemaker aspect. The home health aid hours is more geared towards the medical side, and that may be something like dressing, bathing, helping with toileting, things of that nature. So to apply for either of those benefits, the basic steps are first a discussion with the veteran's primary care physician, and the veteran's primary care physician should make a consult or referral to the social worker who's the coordinator at each VA medical center. And then ideally, the primary care physician would make a really good note, not only that the homemaker home health aid hours are required, but why. For example, maybe noting due to certain conditions, the veteran needs assistance with this or that, or a list of things. So perhaps the better the note from the primary care physician, the more likely that the veteran would get the benefit. Now, what I've seen typically is anywhere from the VA providing 6 up to 21 hours per week. And similar to the care you mentioned earlier, this is going to be the VA contracting with a third-party entity that will be sending someone to the home. And again, that, from what I've seen, that ranges from 6 hours to 21 hours per week. Now, this is also a medical issue, categorically similar to the caregiver benefit. And what I'm getting at is, this is an issue that is appealable also. So let's say hypothetically that the veteran's primary care physician indicates that this veteran is in need of homemaker home health aid hours, and the primary care physician says in the progress notes or the referral that this veteran should ideally receive 15 hours per week. And let's say the benefit is granted, but it's only given at 6 hours per week. Then this is something that could be appealed as well. Or if the benefit was just outright denied, that is an issue that could be appealed in a clinical appeal as well.
Okay, well, thanks, Doug. So VA has mainly two programs, the Veterans Directed Care Program and their home-based community care programs that consist of a host of other programs such as homemaker home health programs. And the big difference I gathered from your explanation between the two programs is under the Veterans Directed Care, VA provides the veteran the money to hire his own attendant, whereas under the homemaker home health care program, VA hires a home health agency or pays a home health agency who then sends an attendant out to the veteran's home to provide the care services. Correct?
Yes, correct, Roscoe.
Okay, great. Well, Doug, thank you for your explanation of the program. And so this concludes our presentation, and now we're going to turn it over to Morgan Brown to talk about construction.
All right. Well, good afternoon, everyone. The nation's lack of adequate long-term care options presents an enormous problem for people with catastrophic disabilities who, because of medical advancements, are living longer. There are very few long-term care facilities that are available of approximately serving veterans with spinal cord injuries or disorders. If I can get the next slide, please. VA is currently operating 6 such facilities, and those are the 6 that are listed there first. Only one of these lies west of the Mississippi River, and that facility at Long Beach only has 12 beds. There are many aging veterans with spinal cord injuries or disabilities that need VA long-term care services, but right now, the department only has the capacity to provide this kind of care for about 180 patients. So as a result, the need far exceeds VA specialized long-term care bed capacity. When this happens, VA does have the authority to place the veteran in a community nursing home, but this is not always possible to find community placements for veterans who are on a ventilator, or may have bowel and bladder care needs. It's also a more costly option for VA. Furthermore, providers in community nursing homes are not trained in providing this type of care, which often results in a compromised quality of care and poor VA outcomes. The reality is that VA needs to expand the number of specialized long-term care facilities and its number of long-term care beds across the VA healthcare system. There are construction projects at San Diego and Dallas, which would eventually increase the number of long-term care SEID beds, but additional capacity is needed. And we're going to talk about those projects here in just a couple of minutes. Next slide. As VA plans and Congress funds the future of VA long-term care, it's essential that they look at a host of factors, including the placement of facilities, the size of rooms, the number of beds, the needs of women veterans with spinal cord injuries or disorders, privacy, isolation, usable space. There's a whole host of factors that have to be taken into consideration. And saying that VA's construction process is complex is probably a big understatement. Convoluted might be in a more appropriate description for what is actually taking place. I say this because once a need is identified, it must go through multiple stages of development, design, and approval, which can take a long time, sometimes even years to complete. VA's Office of Construction and Facilities Management, also known as CFM, is responsible for the planning, design, and construction of every major construction project that's greater than $20 million. And so for the most part, that means virtually every SEI-related facility. In addition, CFM acquires real property for use by VA through the purchase of land and buildings, as well as long-term lease acquisitions. The CFM also manages facility sustainability, seismic corrections, physical security, and historic preservation of VA facilities. They prioritize their construction projects using the strategic capital investment planning process. also known as SKIP, which began in 2010 and was first used in the 2012 budget cycle. The SKIP list is a department-wide planning process that results in the creation of a single integrated prioritized list of projects from the following capital investment accounts: major construction, minor construction, and leases. SKIP was originally designed to improve the delivery of services and benefits for veterans and their families and survivors by addressing VA's most critical needs and/or performance gaps first, investing wisely in VA's future, and then significantly improving the efficiency of VA's far-reaching wide range of activities. From our perspective, the SKIP list hasn't worked out well for a number of reasons. First and foremost, the list changes from one year to the next. So a project listed as a very high priority one year could appear much further down on the list the next. There's also not a lot of transparency in how the list is developed, which is another problem. VA's construction budget is supposed to be based off of the SKIP list, which in many instances, CFM requests for projects don't match up with the industry or local market trends. So instead of asking for the full amount of a project, CFM requests just a portion of it. The practice of not following the industry trend, coupled with deliberate underfunding, often stops projects from moving forward. And by far, insufficient funding is the greatest barrier for VA construction projects moving forward. Last year, Congress appropriated a total of $1.8 billion for VA construction projects. That's all totaled in VA construction funding. But in contrast, it would take anywhere from $60 to $80 billion to complete all of the projects that are on the current SKIP list. Earlier this year, the president did propose that VA receive $18 billion of additional funding in his American Jobs Plan to help VA cover some of this unmet construction need. $3 billion of the amount would be made available immediately for minor VA construction projects and renovations. The remaining $15 billion would be used to handle VA's larger construction projects that take longer to plan and require more careful consideration. The types of projects we're talking about here do include replacing existing facilities or building new ones. And these would most likely be chosen in accordance with the work that will be done in the future here by the Asset and Infrastructure Review Commission, otherwise known as the AIR Commission. Funding for additional SEID long-term care facilities could come from either pot of cash. So we have been working with the House and Senate Veterans Affairs and Appropriations Committees, as well as VA and the administration, to clarify how funding from the American Jobs Plan or from other sources might be used. This includes a recommendation that VA increase the number of staff it has to oversee construction projects. Just like everywhere else in the VA, they don't have the appropriate number of staff to handle a major increase in funding, or for that matter, a larger number of projects. Now, several counter proposals have been made to the president's job plan that do not include funding for the VA. But from our conversations with congressional staff, we know that every effort is being made to provide the department additional construction funding, and it is our goal to try and help secure some of that funding for future SEI long-term care related projects. Now I'd like to invite Mark Lichter, Director of PVA's Architecture Department, to join me for a brief conversation on where we are now with VA long-term care facilities, and then most importantly, what the future looks like in terms of VA long-term care. Welcome, Mark, and thank you for taking time to be with us today.
Thank you, Morgan, and thanks for having me.
All right. So Mark, there's probably no better place to start than the present. So if you would, take a few minutes and talk about the present state of facilities within VA's SEI system of care, to include its current 6 long-term care centers.
Sure. Well, as you mentioned, Morgan, there are only 6 long-term care centers. The VA mandated itself internally to operate 198 long-term care beds. They are only currently operating 173 beds, right around the 180 number that you mentioned. And to put that in perspective, if, across the country, if you divide that by the 50 states, that's less than 4 long-term care beds per state. That's even if they were dispersed across the country, which they are not. But obviously, there are many more spinal cord injured veterans who are eligible for long-term care than 4 in each state. So, and as you mentioned, they're not very well dispersed. There's only one center that's west of the Mississippi, and that is in Long Beach, California. And that's one of the smallest centers at only 12 long-term care beds in their capacity. There are none in the Midwest, none in the Northwest at all. So that's a real problem. Increasing the capacity and also how they're dispersed across the country so that spinal cord injured veterans who need long-term care have access to these specialized facilities. As you mentioned, if they don't have access to the beds, if they're full in their area or they're not in their area at all, then they often, we find, languish in facilities, the nursing homes that are not trained for spinal cord injured patients, and it's a real detriment. They end up in acute care VA facilities anyway in the long run because they're not being cared for properly.
Okay. Earlier, I talked about the American Jobs Plan and PVA's goal to secure funds in that measure or through some other type of legislative vehicle that could be used to renovate existing facilities or build new ones. But I know that PVA's level of involvement extends well beyond securing money for these projects. So for the benefit of our viewers, could you tell us how your department interacts with VA and other entities to design and complete projects to include renovating existing facilities and maybe building future long-term care centers?
Sure, I'd be glad to. So PVA's architecture department, first of all, we help the VA at their request write their criteria and their requirements, which set the spaces, the equipment, the amenities, and how their spinal cord injured facilities are outfitted and how they're built. So we are on a committee and we help them with all their requirements on how to build their facilities. So that's at the ground floor of the process. We also have a seat at the table. We're part of the design team through the entire planning process, as well as overseeing in the construction process through agreement with the VA called Directive 7501. And so we are part of the project team on every project that involves spinal cord injury facilities. As an aside, we also help with other spaces you may not consider, like helping VA medical centers plan the accessibility of anywhere from canteens to clinics that aren't SCI, just helping increase the accessibility around VA hospitals for spinal cord injured veterans. And then we follow up by tracking how well existing facilities are doing because we are part of the site visit team that PVA utilizes along with our medical services department. And we go visit each spinal cord injury facility around the country annually. And so we do assessments of spinal cord injury centers and write up an assessment report of the existing facilities. This allows us to track the needs of facilities, what renovations are needed, what equipment are needed, and that's documented, and that helps us advocate going forward so that we can get the facilities the proper renovations that they need.
All right, well, thanks, Mark, for explaining your department's role on these projects. So next, I'd like to move on to projects that are currently in the queue, which could increase the availability of long-term care bed space in the future. I know that you and several members of the PVA staff attended the groundbreaking ceremony at San Diego recently. So perhaps you could start there and then discuss some of the other projects that might help alleviate the shortage of long-term care for SEID patients in the future.
Absolutely. The ones that are in the immediate future in the queue are, as you mentioned, Morgan, the San Diego Medical Center is building a new spinal cord injury center, and that is to include 20 new long-term care beds. That will be adding 20 long-term care beds to the system, which will certainly help. That is in San Diego, California. So that is obviously an area that needs long-term care beds. That is, construction is underway. They've broken ground, and so that should be completed in about 2 years. So that will really help. And the Dallas VA Medical Center also has a project on the horizon that's been designed, and all of the construction drawings have been completed, so that's ready to go. It is kind of languishing in the contract process right now. However, it is slated to break ground and start construction in the fall of 2022. And that is going to add 30 beds to the system, which will again greatly help. The project also includes 30 quote future long-term care beds that would be added to make the facility a 60-bed long-term care spinal cord injury center. We are working diligently and collaborating with your department, government relations, in trying to expedite the additional 30 beds. The building will already be built, and we are trying to explain to everyone how easy it would be to add those additional 30 beds to a project, which again will already be built, and it wouldn't take much. So that's 30 beds, a potential future 30 beds for a total of 50 if you include San Diego, or 80 if we include the future Dallas beds. In terms of projects on the horizon, those are really the only projects that do not have many hoops to jump through still. So we really need to get some of these projects that are in the early planning stages to get moving along.
Okay. So I know I mentioned earlier that it takes a long time for these projects to come to fruition. Could you give us an idea how long these two projects that you just mentioned have been in the works? And just to clarify, the amount of time that elapsed between the time the project was conceived to the time that we might actually see them accepting veteran patients.
Sure. A project generally will take from the time a need is identified over 10 years, 15 to 20 years is more likely. The San Diego project has been over 10 years in the planning stages. Dallas as well has been over a decade. So it's a very, very long process. And the thing to really keep in mind is that for long-term care veterans, the need is now. So if these projects, the need is identified and a decade goes by, some of these long-term care veterans have been languishing or have passed on. So we really do need to figure a way to expedite projects.
Okay. So aside from the lack of funding, are there other reasons why it takes so long?
Yeah, absolutely. There's, you know, of course, funding. That is the big one. But even when funding is approved, you know, Dallas is a good example. San Diego is a good example. They go through these contracting hoops that they have to jump through that just delay the project. Both Dallas and San Diego have been fully ready to go for years. The construction drawings have all been completed. But there is a process called contracting, and that's writing and negotiating the contracts, which is just an arduous process, which greatly delays, not months, but years, the projects.
Okay. Thanks, Mark. So obviously there's a tremendous need for more long-term care beds now, but the VA's current process coupled with insufficient funding means it could be quite a while before we see any real improvement. Something that could help shorten the chasm between the time the need is identified and the time a facility is built is for more PVA members to speak up with their elected officials about the need for long-term care for veterans with catastrophic injuries. If they heard about the problem more frequently, they're likely to make building or renovating some of these long-term care centers a higher priority. Wouldn't you agree, Mark?
I absolutely would, Morgan. And it's would be such an easy task. Some of these projects are just ready to go, and they just need a push.
Okay. So this concludes our portion of the webinar. So Heather, I'll turn it back over to you for the Q&A session.
Thanks, Morgan, and thanks, Mark, and also Roscoe and Doug for your comments today. We're now going to move into the Q&A section, and we do have some good questions that are teed up from our attendees today. So the first question, and Doug, you might be the best person to answer this one. If a veteran needs a homemaker, home health care, in our experience, is it better if they go through their SCID hub to try to get that care, or could they just as easily go to a spoke? What do you hear it? What do you typically find is better? Well,
Heather, that's a good question. I don't know necessarily whether there is a better or worse. What I typically see is, from where I'm at, is they go through the spoke through their primary care physician. However, I don't see why there would be a problem with talking with the treating physician at the hub. Perhaps the treating physician at the hub has a better rapport with the veteran, maybe knows the veteran's circumstances a little better. So I think it's going to be more on a case-by-case basis, as opposed to painting it broadly that one is better than the other. Perhaps the veteran should really think about which physician at which facility they feel more comfortable with, perhaps, and take it on a case-by-case basis.
Thanks, Doug. Our next question is about the Veteran Directed Care Program. So Roscoe, I'm going to throw this one to you. You mentioned that the program's not available at all VA facilities. So how do veterans find out if the program is available where they are?
That's a good question, Heather. They can talk to the geriatric extended care social worker at their facility to find out if it's offering the program, and they should know whether the program is available there or not. And if it's not available, I recommend that they contact government relations office at their department level, as well as the national level, so that we can begin working with the appropriate congressional representatives and VA central office to find out why isn't it available? Is it lack of funding and so forth, so that we can assist in trying to get the program established at that facility.
Thanks, Roscoe. And we know that there are facilities that are looking into joining the program, and certainly letting your local folks know at the facility that this is a program you want them to take up is helpful. But as Roscoe said, if you can also let your NSO and who can pass it on to PVA Government Relations know of other places where we want the program, it helps us to develop the case that there is a desire from veterans to be able to get this program in additional places. This is a question maybe for Doug. So are CHAMP VA eligible family members also eligible for the VA caregiver benefit program? And if they are, can NSOs help those spouses that are CHAMP VA eligible with their VCP claim, so their caregiver program claim, if it was denied and they hold the power of attorney?
Yes, I can answer that one, Heather. There's no reason that a spouse that has CHAMP VA would not be eligible to be assigned as the caregiver or primary caregiver if they meet all other eligibility criteria. So I guess a better way to say it is CHAMP VA, a recipient of CHAMP VA is not excluded from being designated as a primary caregiver benefit. And the second part of the question is, yes, definitely, a PVA service officer can help with an appeal if one has been denied for this benefit, if we have the veteran's power of attorney.
Great, thanks, Doug. We'll switch it up, go to a couple of construction questions for the moment. So this one's probably for you, Mark. Do you have a status on the Seattle SCI minor expansion project? Has the design been approved, ready for start? Is there funding? Basically anything you can tell us about the Seattle project.
Sure, thanks, Heather. I'd be glad to answer that. So the project, the expansion and renovation of Seattle, we did receive 100% construction drawings the beginning of this year. We reviewed them, our department at PVA, and sent back comments. So the drawings are ready to go, and the project, just FYI, consists of an expansion of the therapy gym, renovation of about 8,000 square feet of the existing SCI center, including converting some of the 4-bed patient rooms into semi-private rooms. Desperately needed. As far as I know, the full funding has not been approved. One of the quirky things the VA does, with oddity, is that they approve the design process in advance of approving the construction funding, which is a problem. So sometimes the drawings sit and it could be years before the shovel goes in the ground. So I can find the latest information on the status of the funding, but as far as I know, it is not fully approved at this point. But the design is ready to go. So I will send out to you an update. Thanks.
Thanks, Mark. Another question. So does CFM, and you can remind all of us what CFM stands for, have a list of future construction projects that involve specifically SCID projects?
Yeah, thanks, Heather. They certainly do. CFM stands for the Office of Construction Facilities Management. So they are the group in the VA's central that manages the construction, the design and the construction of projects. They do have a list, as Morgan mentioned. It's the result of the SCIP process that comes out, and it does come out every year. So that is available online, I believe. But if you want more information, we can certainly get you that list. It does, as Morgan mentioned as well, unfortunately, it does change from year to year, and they're not very transparent about that, which is also part of the problem. So specifically, SCID projects may be scored very high one year and then get bumped down the list in the queue the next year. But that is available, yes.
Thanks, Mark. So now we're going to switch it back to a question about the caregiver program. And Roscoe, I think you can take this one. So we have a veteran. He was medically retired in 1999. So they don't believe that he's currently eligible to apply for the new caregiver program. So should they wait to apply until such time as his era is eligible?
I would, since they're only phase one only includes veterans who served May 7th, 1975 or earlier, I would recommend that they wait until the phase two process begins. We've been told that all of the veterans who were not eligible under the phase one process who applied, and that's part of that large bolus of veterans who were denied, that they're going to have to reapply all over again. So if you're not actually in the phase one, I would encourage you to wait till the phase two. I encourage you to wait until the phase two process begins. But I also want to say that we have been advocating, PVA has been advocating that they start the phase two process sooner. There is no reason that for them to continue to delay the phase two process. They've assured us that the Care Karma, the application tool that they use, is capable of handling all of the phase two veterans. And there is pending legislation to start the phase, change the language of the current legislation so that they can begin phase two sooner. So we're hopeful that it will, the legislation will become effective. It needs to be some amendments to the way it's worded, but we're hopeful that that legislation will give VA the latitude to open phase two up sooner.
Okay, thanks, Roscoe. And another question for you, Roscoe or Doug. Is there any long-term care assistance available through the VA for surviving spouses?
I'm not aware of any assistance. There may be assistance through the CHAMP VA program, because once a CHAMP VA spouse passes on, they retain their benefits. So, but I'm not sure, do they offer any long-term care benefits under the CHAMP VA program to CHAMP beneficiaries?
All right, thank you, Roscoe. And then this will be our final two questions here, back to Mark. So one, do you happen to know the status of the new mental health building at the Long Beach VA?
Yeah, I don't happen to have the status of that project at my fingertips, but I can certainly look into that and send that out. You're listed as anonymous, but if you want to contact me, please feel free and I'll get you that information. Just shoot me an email at markl@pva.org.
All right, thanks, Mark. And the last question also goes to you. I know the architecture department has an accessible home design book, and we had a question about if we have an electronic version of that book.
Well, thanks, Heather. No, we actually don't have an electronic version, but if you're amenable to a print copy, it's very reasonably priced. So if that works for you, it's only $9.99 to members. I don't mean to sound like a used car salesman, but please feel free to contact us for a copy if you'd like one. We do not have it electronically, though. Thanks.
All right, thank you, Mark, and thank you again to all of our presenters. Roscoe, I'm now going to turn it back to you for some quick wrap up.
Okay, Heather. So we have this site for resources that if you want to log on to any of the links that are included, you'll be able to find additional information on the Veterans